Good afternoon, everybody. This is Dr. Scott Worden, the TOS guy, live streaming from Sunnyvale, California. We're definitely heading into fall and winter here. I hope everybody is staying safe with the weather that's coming up around the country. Today, I would like to introduce Dr. Ernest Chan. Dr. Chan is an assistant professor of surgery at the University of Chicago in the section of thoracic surgery. Dr. Chan completed an integrated cardiothoracic surgery residency along with an advanced lung failure fellowship at the University of Pittsburgh Medical Center, a very prestigious center. Dr. Chan currently specializes in minimally invasive robotic surgery for malignant and benign diseases of the chest. He was recruited to the University of Chicago to help expand their use and their program of robotic surgery in thoracic surgery patients. Dr. Chan created the Robotic Intrathoracic First Rib program there for patients with Thoracic Outlet Syndrome. Along with leadership in other divisions and departments, Dr. Chan is in the process of formalizing this program to create a multidisciplinary thoracic outlet program, which we often discuss here. This will involve plastic surgery, orthopedic surgery, vascular surgery, anesthesia, interventional radiology, and physical therapy. And Dr. Chan, that's a very impressive resume. Thank you for joining us today.
Thanks for having me.
We have a short agenda, which I'm going to let you expand upon greatly. First thing I'd like to ask you is when you see a new patient with thoracic outlet syndrome, could you please describe your workup?
That's a great question. So I would like to start off by sharing my slides, if that's okay. And the slides will kind of go through exactly everything that I go through from, meeting them to surgery to, what we finish off with follow-up, etc. So just going to share my slides. Can you see my slides?
Working on it, and there we go.
All right. So I usually talk to the patients basically about what is going on when I first see them. And a lot of times these patients come and they know exactly what's going on already in terms of what is TOS. And we talk about this anatomy here and specifically where that first rib is in conjunction with the vein, the artery, and the brachial plexus going down the arm. So if you look at this, and these are just several images, you can see that that area is very, very narrow to begin with. And it only gets smaller when you lift your arm. And there's three types. The most common for sure is going to be neurogenic. But venous is actually probably our most common one of where we operate on, because neurogenic is a little bit more difficult to pronounce and to diagnose, given that there's really no specific test that'll tell us, yes, the nerves are specifically compressed compared to our venous or arterial side, where we can actually see the flow significantly decrease. And this is kind of the pathology of what's going on, what is potentially crushing or compressing the vein and the nerves. So specifically for me, I do this transthoracically or robotically. This is the view that I see. And I particularly think that this is going to be your most reproducible operation, but also the operation where I'm going to remove the most of the rib. So you can see this is my typical view in the operating room. And I'm basically seeing the entire rib from sternum to spine. And typically, I've gone as far back as I can just to try to avoid leaving some of the rib behind. Once the rib is removed, this is my view. And I really think that the view that I have is next to none. With the robotic approach, our view is 10 times zoomed in. And you can basically see everything. You can see the vein, the artery, and the nerves here all the way posteriorly. This is a left-sided. And then you can see the muscle in between, as well as in the back on the screen right. That's going to be your middle scalene muscle. This muscle, you can see it's completely draped on that nerve there, and that's what we remove for a neurolysis. So I think the benefits of the robotic approach is going to be better visualization. You can see all the surrounding structures, the phrenic nerve, to avoid all this injury. You have the complete resection of the rib in its entirety, as well as decrease postoperative complications. Now, for the audience, I just left some of these papers. I think these are seminal papers in the current workup of robotic first rib resection. Dr. Burt has really pioneered this this area along with several others. And this was one of the first papers that really compared, first rib resection robotically with other modalities, and they saw that there was some superiority to other techniques. I just leave this here just for education purposes. If some of the audience wants to look up this paper, and everything that we try to do, we try to mimic, research-led, literature-led approaches to what we do in the operating room. Dr. Garga, I always pronounce his last name incorrectly, but the first author of this paper, again, he was one of the first surgeons who really championed this operation. And thankfully, I was able to kind of, learn these operations from these surgeons. They, he showed that these patients do very, very well, specifically for venous thoracic outlet when you perform this operation robotically. So in terms of answering kind of your question on what my workflow is, this is basically how my workflow is. And I mirror what I do to what Dr. Burt does, because he has such a high volume and he has such a high success rate. Now, if you look on the left, the first thing is going to be, physical exam. Physical exam, questioning the patient, what's going on, what are their exact symptoms. That is going to be key, because every patient is going to have different symptoms. They're going to have, a different course, not only what the symptoms are, but how they got there. And that's very important. In terms of diagnosis and diagnostic testing, I'm on the side of getting more testing than less, especially for neurogenic TOS. It's so difficult to diagnose these patients. There's so many different areas down the arm, the pec minor, for example, where the nerves could be compressed. So you really want to do the right operation for these patients. In addition to that, some patients will have multiple areas of compression, not just one. So in order to get a successful operation, successful story, you really need to tease these things out. In terms of therapy specifically, that's going to change a little bit depending on if you have neurogenic, if you have venous, or you can have a combination of both. In terms of my follow-up, I usually see my patients 2 weeks after surgery. And then in addition to seeing me, they're going to continue some physical therapy. If they need additional workup, they can work with my anesthesia team to get additional blocks. And if they need, further surgery, pec minor releases or additional releases, then, they can see, some of the other surgical disciplines. Again, for neurogenic, this is everything that I do. Everything is systematic. Everything is done the exact same way for all of these patients because they're so difficult to diagnose. I'm very grateful and thankful that I have people like Roy Horton, our main physical therapist, who's recruited a whole team of therapists so that, these patients have the flexibility of seeing physical therapy when they need to. And then Dr. Pan has been excellent for me at the University of Chicago for scaling blocks, but also for other blocks. I think I can end here, but in terms of workflow after surgery, which I think is equally as important as before surgery, because a lot of these patients are going to have other issues, okay? They're going to have pec minor syndrome. They're going to have, I've had a patient who had trauma in the upper extremity left side and also the trapezius area. So he needed some releases from there as well. And I think without, the collaboration with orthopedics, that patient would have still continued to have bad TOS if we didn't work together. So all in all, I think you see on the screen here, it's really not just myself. I thank Scott for really saying that, we potentially have started something really good here at the University of Chicago, but there are a lot of people that are backing me up, that are, that I can just call at a whim to say, hey, I have this patient, he's super complex. for reasons XYZ. Can you take a look at him? And everybody's just so collaborative here. And I think this is key to increase your success rate. This is key to make sure patients are happy with everything that is going on after surgery. And it's not just a cut first. It's a lot of thinking involved.
Already in a nice organized manner.
Yeah.
So I want to bring up some points and go into them in more detail if I could. Number one, having a multi-specialty group is wonderful. Mm-hmm. In our opinion, because of the complexity of these patients and the broad differential diagnosis, a patient with left upper extremity pain doesn't always have neurogenic TOS. That seems to be invaluable. You have so many people working with you.
Yeah, and so I may put myself out of business, but I'm really in the belief that every surgery is going to have a specific population that it's better for. For example, if someone's already had a transthoracic or a transaxillary or supraclavicular approach to a first rib resection, then maybe the robotic approach is better for that patient because there's less scar tissue from the chest, or vice versa, right? So I think that reason alone, I think you really need to work with other colleagues. Personally, I don't know how to do a pec minor release, for example. So I think that, having all those people there benefits only the patients.
So let's go into some of that in detail. Is pec minor syndrome a form of TOS? Is it uniformly within every diagnosis of TOS? How do you feel about that?
Sure. I think I would say that's a controversial statement. There's some people are going to go one way and versus the other. I think the way that I approach that comment is does that really matter, right? Because, and the reason I say that is because, a lot of times these patients will have multiple areas where things are compressed. Once you release the rib, the pec minor is the next place where those nerves go down. So I think to really separate those, I've personally, I haven't dealt with a patient that just had pec minor syndrome. I'm sure that exists, but I think that you have to treat each patient for what they are and what they present with. So if that patient needs, pec minor release with the first rib, I mean, does it really matter to the patient that, is that the same thing or is it not, right? So, we've definitely had patients where we remove the first rib and they still have had issues. And, the answer is going to, is the patient doesn't care whether they're together. What matters is getting them to the right person, going to anesthesia, to pain, getting that block to further diagnose that pec minor issue and getting that treated, and getting them to the right person, which is not me for that instance. It's orthopedics or plastic surgery.
So having discussed that in a little detail, how do you plan your blocks? Do you have a specific algorithm? Does it depend on specific symptoms that come up? Where do you do them? How many do you do at the same time, if any? And what do you do with the results?
Yeah, so I'm heavily reliant on my anesthesia colleagues. Dr. Pan has done fellowships in regional blockage and all that. So he deals specifically with all that. But I think some of the rules that you really have to rely on is, one, you need to tell the patient that, this can be therapeutic, but only for a little bit. Because a lot of patients will think, oh, this feels great. And then all of a sudden, all the symptoms, all come back. And a lot of times they come back very significant compared to before. Mm-hmm. I usually try to do one block at a time. And I'm really reliant on what Dr. Pan thinks. So he actually, part of our requirement is, each of us sees the patient and does our own physical exam and our own history and physical. So Dr. Pan will do his entire own thing completely separate from me. And then he'll decide, this is the kind of block we think. We always, if we're concerned with thoracic outlet, we always try the scalene block first.
The
And he's
anterior scaling.
correct, the anterior scaling block first. And if that isn't a positive exam, meaning, or a positive test, meaning the symptoms have resolved, then, Dr. Pan and I will have a discussion. Hey, based on his physical exam, we may need to go down the arm. There might be something around the scapula that's worrying the patient, etc.
So in that case, you might add a trapezius block.
Sure. Yeah, yeah. But we try to do one block at a time, just because if you do, in our mind, if we do multiple, that kind of muddies the water a little bit, and we're not sure exactly which one is helping the patient. So.
Right. So if you do multiple blocks at the same time, you're not going to find the pain generator.
Correct. Yeah.
Now, you had mentioned very interesting McCleary syndrome, which not many people talk about.
Mhm.
And for our listeners, McCleary syndrome is a form of venous TOS with no blood clot. It's where certain positions of the arm obstruct the subclavian veins and cause symptoms. Because from the radiology literature, I can tell you a lot of people compress their veins when their arms are up. So
Yes.
asymptomatic compression of the veins doesn't mean anything. It's probably normal physiologic, but
Yes.
compression of the veins with symptoms. So you mentioned that, and Dr. Gargaslu, I've worked with him a lot.
I'm glad you're able to pronounce that.
That's from a lot of practice. He's a great guy. He really cares about his patients. He's very progressive. And he and I have spent a lot of time discussing what happens when you have venous compression in terms of secondary congestive neuropathy is a term that some people use. I like that term. That the increased venous pressure will cause upstream from the subclavian vein, meaning into the arm, that the blood won't drain as easily. And so it slowly seeps through blood vessels and creates a subclinical form of edema, and then can increase the amount of fibrin and other biologically active agents. How does that, do you have any comments on that, first of all?
Yeah, sure. I think that's completely underdiagnosed. In my mind, I think you're foolish to say otherwise. I mean, the fact of the matter is, on my other side of my surgeries, I do a lot of cancer operations, and some of these patients will have foreign objects such as catheters in their arms, etc. And those people end up getting upper extremity DVTs. Okay, so I think that that goes back to having potentially what we call the one hit or two hit theory. You have one hit where it's the rib, right? It's causing McCleary syndrome, but you're not getting blood clots, right? And then when you get into that scenario where you have the second hit, whether it's a foreign object or you're hospitalized, or you get into some thrombogenic state such as COVID, for example, right? Then you get blood clots, right? So that definitely is something that is completely underdiagnosed, and I think that's real. I think the overarching thing that is happening is you're causing inflammation, right? And we all know that inflammation anywhere in your body leads to bad pathology, infections, increased advanced aging, cancers, etc. We know that. So the fact that this process is happening and you're getting kind of fibrotic deposits throughout your arm and repeated insults over decades potentially, right? That it'll only lead to bad things. So unfortunately, I've thought about this issue because I do think even around a big university such as University of Chicago, this thing is underdiagnosed. And I'd love to know your thoughts on how we can potentially get these patients and spread the word to identify these patients, because ultimately, for a lot of patients, if they don't have like a tangible thing such as a clot in their arm, why get surgery, right?
I think that's a wonderful point. I think we need to upgrade our definition of the disease and our understanding anatomically. That's why I do what I do. For our audience, I have never worked on a common patient with Dr. Chan to this date. We've really only met him a short while ago. So he's not familiar with what we do. But when I see veins being compressed, the subclavian veins, I'm aware of the literature. It could be totally normal. It could be pathologic. So
Sure.
we, on our MRI, we look for signs of congestion, such as the cephalic vein being distended when the arms are up, but not when the arms are down. Also, I believe that ultrasound, while I don't think it provides much help for neurogenic TOS,
Mhm.
I think it is invaluable in reproducing the position for the patient that causes symptoms if they have venous thoracic outlet syndrome or McCleary syndrome.
Sure.
And being a believer in what Dr. G does, and I think you had an excellent discussion on it, the presence of ongoing chronic venous congestion that doesn't feel any different to the patient immediately, but builds up over months to years. I think that is something we should evaluate in patients. They may have compression of the plexus between the first rib and the collarbone, and at the same time, limited venous drainage, which just compounds it. So I know that Dr. G does angiograms and looks for compression of the veins as a primary, excuse me, as a primary sign that explains both, well, venous and neurogenic TOS. And a lot of the patients he operates in don't have the frank, obvious blood clot, but they have something going on, and he's had a good success rate.
So
Dr. Bo-
I just wanted to add to that. That's another reason. Even if I'm working my patients up for venous, for neurogenic, a lot of times I will still get a venogram because I've seen patients, get the venogram and there is complete compression, but like you said, no blood clots. And then you go in there and you take the first rib out, and there's an area of the vein that's kinked, and that area is a little bit more fibrotic than the rest of the vein.
Great.
And so that, in my mind, every time I'm doing this operation, I'm always trying to find these little tidbits of, oh, if I now know that if I remove this rib and I do the venolysis, etc., that will help the patient. If I go in there and the vein looks beautiful and the nerves look great, they all look untouched, then I start questioning myself, like, hey, am I really helping the patient, or am I actually removing some pathology? So I've had a couple of patients that came in for neurogenic, and we, did a complete venolysis as well, because on the venogram, there is kinkage. And, I don't know, it's tough to create the study where, for neurogenic patients, if you also do a venolysis, will they get recurrent TOS, right? Because we do know 10-15% of patients will get recurrent TOS after
Right.
surgery. So the
Actually,
question
up to
is,
30% if you go out 2 years.
that's correct. So, I feel like
It
when
just
if you're
shows
there,
we're missing something, that our
right?
model is incomplete.
Absolutely. So for me, if I'm there, I'm going to try to free everything up as much as I can. The only thing that I'm a little bit weary about is the nerves. If you have no neurogenic symptoms at all, I'll still remove the middle scalene muscle, but I'll try to minimize separating the nerves, just because you're going to get, scar
Mm.
tissue anyway. And I think that the nature scar tissue is probably way better than, stuff that we do after surgery. So.
Right. So to go back to some of the advantages and disadvantages of robotic surgery, as you brought up, you have less ability with robotic, I believe, to fully dissect away the scalene muscles. Is that a fair statement?
I don't think so. I'm pretty aggressive about, removing the anterior and the middle scalene. So the anterior scalene, I basically will remove it until I will remove the entire muscle past the vein and the artery. So there's completely nothing left between the vein and the artery. And then
Okay.
the middle scalene muscle, I'll go as far as I can, and I will do the same thing. I'll tunnel all the way, proximally until they're completely off the nerves. I think where the robotic intrathoracic approach fails is going more peripherally on the nerves, as the nerves kind of go towards the shoulder and into the arm.
Mm.
So clearly I can't go that far. So, I can't do a concurrent pec minor release or anything like that. So I think that's where it falls short. The question is, where's the compression? And I think
Right.
for some patients, the chest is enough, and for others, you might need to do 2 operations. So that would be my major flaw.
This is where a detailed MRI can tell you what's being compressed
Absolutely.
and where it's being compressed. And we work a lot on this. I always bring this up. I'll say it again this time. Pete, R.M. Pete, who wrote the seminal paper naming TOS in 1956,
Mhm.
he clearly describes the fact that there's tons of anatomic variants that are known and tons of etiologies or causes of this neurovascular syndrome they knew at the time. And he said, let's lump them together right after he said there's a million different types. So that unfortunately, I think, has made it harder for us. We're forcing it into a box. And I think you know better than me from your anatomic challenges as you do these, every patient's a little different.
It is. I just did a patient, her middle and anterior scalene muscle was one big giant muscle. They weren't separate. I mean, that was probably
Yeah.
one of the first times I've seen that, but I think it doesn't change my surgical approach. But like you said, every patient is different. That's only going to make this diagnosis harder. So
We see on my MRI, we see tremendous variation in the size and the insertions of the anterior and middle scalene muscles. We see very often that the origin of these muscles is just a big gamish. There aren't two separate muscles. It's kind of this woven appearance of muscle with the components of the brachial plexus passing between my fingers, which
right,
represents the
exactly.
muscle. And if you see that and there's no other compression when they raise their arms, I think that's a different patient than the ones who just have severe compression between the rib and the collarbone.
Hmm. Absolutely.
So this is one where I think, I've worked in multimodality groups. It's hard to keep private practice doctors together for this sort of thing,
Mhm.
but it's been very helpful to have all those different inputs, mine included, I hope. Um, Let me go back to some of the things you're talking about. You do in your protocol, I believe you do physical therapy, and then if it fails at 4 weeks, that's when you start considering first rib resection. Is that correct?
That's correct. So I would say at least 50, maybe even upwards to 70% of people will actually do very well with physical therapy, and a lot of their symptoms will minimize to the point where they don't want surgery. And I think the great thing about this diagnosis is it's not a life-threatening diagnosis, so we have a lot of time to work these patients up. I'm a
Mhm.
surgeon. I love doing surgery. I think that, I get a lot of satisfaction from doing surgery. But the caveat is it has to help the patient. Otherwise, I feel like I've done a disservice. So, I think physical therapy is such an easy thing to go through. And I do think that while this statement is difficult to kind of back up, I do think having the physical therapy before surgery, I think helps the recovery after surgery because like you said, everybody's anatomy is very different, and a lot of these patients are going to need some form of physical therapy after the surgery anyway, in addition to kind of long-term physical therapy for themselves. The great thing about our physical therapy program that was created by Roy Horton is the goal of it is to not keep you as a patient forever. So the goal of it is to give you the tools so that you can go on your merry life to do those
Mhm.
physical therapy exercises at home and at your own leisure in between, cases when you're at work or, during lunchtime while you're at work. So I think that coming to a session once a week is not enough. You're going to have to really be proactive and do those things at home. And Roy and his team really help you for that.
Do you ever do blocks like Botox to help patients get deeper into physical therapy with less pain for a few months?
I think that Dr. Pan has been great and so accessible to all my patients, and we haven't had to do that yet in the last year, but that is certainly absolutely readily available for our patients, and I think that that does help, especially for those patients that have had TOS symptoms for years on end, and we've all seen the guy or the gal that has gone to multiple specialists and they don't know what's going on, right? That still
It's
happens. And
frustrating.
yeah, and the longer you have these symptoms, the worse they get. So I think that I would probably selectively use that for those patients, but we haven't had to do so yet.
Excellent. I think, in the literature, a lot of people in the past couple of decades have recommended physical therapy for 6 or even 12 months before first rib resection. Do you feel that's being updated now because we have better understanding of the progress of the disease, or maybe because we're recognizing it sooner?
I think so, but I also think that there's more and more surgeons out there that are capable of doing this operation. So I think that helps when your access to this operation and to other treatment modalities has improved significantly. Gone are the days where we had to travel between state lines just to get help with this operation or with this therapy. So I also think that within the physical therapy world, they're starting to have physical therapists that are specialized in physical therapy for TOS, and that's our group at University of Chicago. We have about 5 or 6 people that they don't get sent to anybody else other than these 5 or 6 people, and all of that goes through Roy Horton, who's the head of that. So for TOS, so I think
that might be a great conversation for one of our live streams in the future to help patients understand what your folks are doing if they're amenable to being on and talking.
Yeah, we should definitely get Roy involved. He's been a blessing for our program this year, and hopefully we expand it more as they get more physical therapists involved and things like that. So
let me ask you a hypothetical question, if I could, Doc. 20 years from now, what would you like to see the state of TOS diagnosis and treatment be changed?
Yeah, that's a great question. I think the one thing that we're missing is that golden diagnosis or that golden diagnostic test, right? For lung cancer, we have a CT scan. We can see where it is. We can see what the borders are. We can cut it out, etc. We just don't have that for neurogenic TOS. I think when EMGs got really good in the early 90s, there was a lot of promise with that, but unfortunately, it's just fallen short. I don't know why. I have speculations on why, with neurogenic being pretty a dynamic diagnosis position-wise, for example. But I hope that there's some test one day, whether it's some imaging that for example, that you do that's so well detailed and detail oriented on that area. But I don't know. I don't know what the answer is, but that would be great.
So pre-op, we'd like to have a more sensitive and specific test.
Yeah.
Okay. Great. Anything else you'd like to add at this point?
I would just again try to plug our university and our program. University of Chicago has been a leader in our area for decades in surgery. I think this is no different. TOS is, while we have a multidisciplinary approach, I think at the end of the day, most of it is it's a surgical problem that once decompressed is the first step to getting better. And come down, and we'd be happy to take care of anybody.
Great. And how can people reach out and contact you?
Yeah, so if you just go onto our University of Chicago website and you look me up, you should be able to get right into my clinic. They'll give a number to you and somebody to contact so that it'll come through our system.
Wonderful. I don't think we have any questions from viewers. I bet you everybody's getting ready for the holiday. So, well, we did get one just as I said that, just to make it look bad. All right. Jim in St. Louis says, who's the first physician that I should make an appointment with to diagnose TOS at the University of Chicago?
So I'm happy to see you, Jim from St. Louis. So I can put my clinic and scheduling phone number in the chat, and then you can just call, say you want to make an appointment for Ernest Chan for Thoracic Outlet. And the first step we do is we go through all the insurance and all that to make sure we're not wasting your time coming all the way to Chicago to see me. And then if everything passes, I'm happy to see what we can do for you.
And that's not really that long a trip from St. Louis.
So should I put my clinic number in this comment section? Is that?
We'll take care of it later. We will add to the video your contact info. And I will also, when patients reach out to us and they are in the Midwest, I will definitely give them your contact information.
That sounds great.
All right. Anything else at this point you think you could add?
I don't think so.
All right. Well, we thank you very much for your time and for answering the question.
I think we got another one. We have another question right here from David from Florida. Do you have a sense of outcomes for robotic surgery for TOS? Yeah, so the numbers that I usually quote are, I would say about 70 to 80% of patients will have a significant improvement in the in specifically symptomatic relief from TOS. That usually takes about, I would say, 4 to 6 weeks. Some patients will actually feel immediate relief as well in the post-op period. So that's always good as well. So I would say about 70 to 80%. And I personally think the operation is not the defining factor for symptom relief. It's going to be your workup. So we need to make sure before surgery, we're choosing the right patients and making sure that, you know, the patient is getting exactly what they need. Because unfortunately, some of these patients, as I mentioned earlier, will have multiple syndromes or multiple areas of compression that all need to be dealt with.
I think that comparing it to the traditional most common types, either transaxillary or supraclavicular, I think the results are the same or better in robotic surgery. Is that correct?
Yeah. I would say it's at least the same. Sometimes it is better just because of the visualization and what we're able to do from inside the chest. I think one of the major differences is because my visualization and my instrumentation is significantly better, in my opinion, to the open procedure. It's extensively more reproducible. So this is an operation that is not commonly done. The definition of it being commonly done is doing maybe 1 a week, if at best. And so in order to champion a procedure like this, you really have to put all your eggs into the other baskets, making it reproducible, making the visualization easier. And because of the robotic platform with Intuitive, I think even if you're doing 1 a month, the view is just so much better that, you know, you don't need to do 1,000 of them in your career in order to do it well.
So the outcomes are the same as traditional forms of surgery, but the complications are less.
Absolutely. Yeah.
Good. Herb, do we have any other questions? Okay. People are getting ready for Thanksgiving.
Yeah.
All right. Thanks, Dr. Chan. Really appreciate it. And to all our viewers, in 2 weeks, I'll be doing another live stream talking about the rash of recent athletes with big names that have been diagnosed with forms of TOS. So be sure to attend that 2 weeks from today. Again, this is Dr. Scott Worden, the TOS guy. Thank you all. And thank you, Dr. Chan.
All right. Have a good night.